Good morning, everyone. So I thank the organizers for giving me this opportunity. So first, coming to the basics of diastole. So as we have read in our first MBBS, diastole has got four components. It has got isovolumetric relaxation, rapid inflow through the mitral valve, diastasis, followed by atrial systole. And if we do our transmitral Doppler, the normal pattern which we see is E is more than A and E prime is more than A prime. And there are the grades of diastolic dysfunction that we all know, that grade 1 is E more than A, grade 2 is E becomes more than A. Sorry, grade 1 is E less than A, grade 2 is E more than A. And in grade 3 and 4, E becomes nearly 2 times that of A with the reduction of E prime. So in the physiology of heart failure with preserved EF, what essentially happens is the LV end diastolic pressure goes up, the LV end diastolic volume comes down, and there's a reduction in the stroke volume as the ejection fraction is fixed. The elevated LV end diastolic pressure leads to an elevation of the left atrial pressure, leading to an elevation of the pulmonary venous pressure, pulmonary capillary wedge pressure, elevation of the pulmonary arterial pressure, which consequently leads to elevation of the RV end diastolic pressure, and finally the RA pressure gets elevated, leading to congestive cardiac failure. And this is the PV loop, which is seen in patients with HFpEF. So as compared with the normal person, the LV end diastolic pressure goes up, the LV end diastolic volume comes down, and the stroke volume also comes down. So this is the summary of the hemodynamics, what happens in patients with heart failure with preserved EF. So in the algorithm where we for diagnosis of heart failure with preserved EF, so there are four components which have to be assessed. That is the average E by E prime more than 14, septal E prime less than 7 or lateral E prime less than 10, TR velocity more than 2.8, and the LA volume index more than 34. So out of these four, if more than 2 are positive, diastolic dysfunction is definitely there. If less than 2 are positive, then it is not there. But the gray zone is there when 50% become positive. That's what to do when 2 are positive. So this is another algorithm showing the same. So E by A less than 0.8 with E of less than 50 with grade 1 diastolic dysfunction, that indicates the LA pressure is normal. Again, when the E by A is more than 2, we know that it's a grade 3 diastolic dysfunction and the LA pressure is elevated. But when the E by A is is less than 0.8, E more than 50, or E by A is between 0.8 to 2, then we are again at a fix. We are not sure what actually is there. Same thing with the E prime velocity on tissue Doppler. The E prime is more than 10, it is normal. E prime is less than 10, we have to check for E by E prime. So E by E prime 9 to 12 is grade 2, E by E prime more than 13 is grade 3, and E by E prime less than 8 is grade 1. So if we subject a patient, a normal individual, to stress in the form of a treadmill or a ergometric exercise, what happens to the diastolic parameters? So the diastolic filling time gets shortened, the myocardial relaxation time gets shortened, diastolic filling is accelerated, there is increased suction force in the LV during early diastole, the LV EDP comes down, and the LA pressure is unchanged. So that leads to an increased transmitral gradient. It enhances the flow of blood from the LA to the LV across the mitral valve. So this was a study published in 2003 where they analyzed the effects of treadmill exercise on mitral inflow and annular velocities in healthy adults. They had included 31 healthy individuals, and they found that the transmitral, the E velocity got increased, and there was a proportional increase in the A velocity as well, and there was an increase in the E prime velocity as well. So the E by A ratio and the E by E prime ratio were unchanged in healthy individuals. What happens in patients with HFpEF post-stress? So this was a study where they included echo parameters as well as invasive hemodynamics. So what we found on baseline, patients with HFpEF, they were older and they had a higher BMI. And on echocardiogram, those with HFpEF, they had a higher E by E prime ratio, and they had evidence of LV hypertrophy and LA enlargement. Next, coming to cardiac cath at rest, what they found was those with HFpEF, they had higher RA pressure, higher PA systolic as well as mean pressure. The wedge pressure was also elevated. The LV EDP was more or less similar between the two groups. However, for the normal individuals, systolic blood pressure went up much higher. RA pressure, PA systolic pressure, mean PA pressure, wedge pressure, and LV EDP all went up significantly. However, it's interesting to note that the cardiac index came down in these patients with HFpEF. So this is the trend on the trend which they had observed during exercise. So the difference in wedge pressure which was there at baseline was not significant, but with exercise the difference became augmented, and the maximum difference was seen during peak exercise. Similar observations were seen in the LV EDP and the PA mean pressures. Exercises just augmented the difference between the two groups. And also there were significant differences which were seen in the difference in the SVRI, difference in augmentation of the heart rate, difference in augmentation of the systolic blood pressure, as well as the cardiac index. And so the ROC showed that the significant parameters which could exclude patients controls from patients with HFpEF were the exercise PS systolic pressure, the leg raise pulmonary capillary wedge pressure, resting PS systolic pressure, and the E by E prime ratio on echocardiogram. So again, this was like one more study. It was done from Australia as well as the Netherlands in hemodynamic basis of exercise limitation in patients with heart failure with preserved EF. Similarly, they found that at rest, the tissue Doppler velocities S prime and E prime were much less in those patients with HFpEF. The E by E prime was elevated. And they again did a cardiac cath at rest and post exercise, and they found that although at baseline there was not significant difference between the wedge pressure and the PS systolic pressure, the SVRI was significantly elevated in those with HFpEF, and at peak exercise these differences were much more augmented. So it just unmasked the differences which were not there at baseline. And this is again the graph which showed that on exercise how the parameters change and the difference gets augmented. So the summary of this entire thing of these studies are that in patients with HFpEF with exercise, RA pressure goes up, PS systolic pressure goes up, mean PA pressure goes up, pulmonary capillary wedge pressure and elevated and LV end-diastolic pressure, they go up much more than patients who are normal. Mean arterial pressure also goes up. Cardiac index cannot be the patients with HFpEF they can't increase their cardiac index so much. PVRI and SVRI they are not much affected with exercise in the HFpEF, but in normal patients they come down. So the rationale of a diastolic stress echo is that, again as I've said, that it unmasks the exercise related elevation of PA pressure, wedge pressure and LV end-diastolic pressure in patients with normal parameters at rest. So the protocol which is followed is first you have to get a baseline echo, and then we have to subject the patient to exercise, either treadmill or an ergometer, and then we have to acquire the post-exercise echo images within 90 seconds of termination. So these are the protocols that we use for bicycle ergometer. It is 25 watts. For treadmill, it's a standard Bruce protocol which is used. The parameters which are measured are the LV ejection fraction, wall motion abnormality, E and A, E prime, A prime, and the tricuspid velocity. So a positive test is indicated by 2 or more of them, that average E by E prime is more than 14, septal E by E prime is more than 15, TR velocity more than 2.8, and E prime is of less than 7. For elderly patients, we have got something called a Cardiff media protocol which is used. So this is an illustrative case. At rest, the E wave is 0.6, E prime is 4, rest E by E prime is 14, RVSP is 27, and TR velocity is 2.2. Post exercise, we see that E has gone up significantly, 1.2. E prime has not increased that much. So E by E prime post exercise is 17, and peak TR velocity post exercise is 2.9. So 2 are positive. So this is a positive stress test. Similarly, in case number 2, the E prime at rest is 0.4, E by E prime is 5, rest E prime is 9, TR velocity is 2. Post exercise, we find that E by E prime is 7 and TR velocity is 2.7. So this is negative. Case 3, at rest E is 0.9, E by E prime is 10, TR velocity is 2.5. Post exercise, the E by E prime becomes as high as 18 and the RVSP becomes 57, TR velocity is 3.5. It again becomes elevated. So this is again a positive test. So this is how we evaluate a patient. Patient coming as to suspected heart failure, we do a full biochemistry, pro-BNP, electrolytes, RFT, ECG, blood count, X-ray. If we suspect heart failure, we get a screening echo done, LVF more than 50%. Then we assess the resting diastolic function. If there is grade 1 diastolic dysfunction, patient is symptomatic, we can subject him to a stress test to unmask the parameters. And the grade 2 or grade 3 diastolic dysfunction, we might still go ahead with a stress test, but it more or less tells that the patient has got HFpEF. Prognostic implication, the patient with a positive diastolic stress test has got increased risk of cardiovascular death, hospitalization, MACE, and new onset atrial fibrillation. So pros and cons of each. So basically in the We use a apical four-chamber view to see the E and A, but the problem is with exercise, E and A tends to fuse at higher heart rate, so measurement might be difficult. PS systolic pressure by the tricuspid velocity is much easier. It is not affected much by heart rate. The AAC and the ESCVI guidelines, they also recommend a diastolic stress testing for patients who are symptomatic with grade 1 diastolic dysfunction as rest, and they are asked to measure the parameters as I've already told. So diastolic stress echo is useful in unmasking diastolic dysfunction in a symptomatic patient. The parameters have to be recorded within 120 seconds of exercise termination, and a positive test is a major predictor of cardiovascular death, hospitalization, MACE, and new onset AFib. Thank you for your patient hearing.